So somebody said a question now, which is about stakeholders, or where do we actually engage with the NHI. So one of the slogans that I thought we should also just add here at the end that I'm going to talk about so I don't forget is about stakeholders. And I will talk to you about where in the bill at the moment you can engage with the NHI. Where are the structures that the NHI says you'll be able to talk to government about? Okay, because it's different than what exists now. Okay, there will be some new structures that we might have to learn about, and that will be important. Okay, but before we do that, before we go back to the NHI, Lydia's just asked me to talk a little bit about the health market inquiry. Has anyone heard of the health market inquiry before? HMI, health market inquiry. No one. Okay, it started in 2014. I'm just going to call it HMI. Hey? So this is happening. Oh yeah, that's better. Yeah. This is happening since 2014, which is while we were already talking about the NHI. Okay. Well, the government said there's something wrong in those numbers that we looked at earlier, the numbers, the 4.2, the percentage of spending in healthcare. Okay, how come there's so much money being spent in the private sector and it's equal amounts of money to the public sector, but they're seeing so much less patients? What's happening? What's wrong in the private sector? And how can we help them get better outcomes? Okay, and they said that there's something unequal going on in the private sector that we need to actually look at. And they made this report. It took 5 years for them to write the report. And it came out in 2019, which is unfortunately just before COVID. Okay? So at the end of 2019, we got this report which actually gave us some solutions to make the private sector not cost so much money. Okay? And 2019, 2020 came around, COVID came about, everyone forgot about these recommendations. People started talking about the NHI again, the NHI got signed into law, and we forgot about some of these recommendations. That we could actually do to improve the cost in the private sector. So like Lydia was saying, you have the Woolworths and you have the Boxer superstore. How can we make it so that when you go to Woolworths under the NHI in future, it doesn't cost so much money to get whatever you're buying? Okay. How can we reduce the price of the Woolworths? Okay, that's the question. So we're not getting rid of it, but we're reducing the price so that if it comes under the NHI banner in future, it is not costing so much money for people. And that's what some of the recommendations of the HMI were, okay, around those issues. So firstly, before we talk about that, let's say, when you say the private sector, what do people think of? Private sector. You think money, but what do you think of? But it's a business, eh? You think so private sector, I'm just going to say PVT for private, eh? So you say it's a business. But what's included? What's all the parts of the private sector? Who's in the private sector? Is it something? So it's outside of government. I'm talking about private healthcare sectors here, especially. So it's businesses outside of government. So maybe it's hospitals you think of. Hey, maybe it's the big hospitals that you think of. Maybe it's some private doctors, GPs. Hey. Some private dentists. Maybe if you're a physiotherapist, you go to a physio outside. What else? What else is part of the private sector? Psychiatry, maybe. Some specialists. Eh? Yeah, Lydia said earlier. So there's lots of specialists in the private sector. I think it was like 60% of the total plus, eh? That are in the private sector, even though. But what else is in the private sector that we're not talking about here? Okay, so when you're thinking of the private sector, we're thinking of it as one thing. Okay, and the point I'm trying to make is it's not one thing, especially compared to the public sector. It's not one thing. There are three big parts of the private sector that the HMI tried to figure out. Okay? Part one is the providers. Okay, these are the GPs, the dentists, etc. Okay? So these are the practitioners. So these are the people who are actually doing the operations, who are giving the medicine, the nurses, the whatever, etc. Okay, but that's only one of three parts of the private sector. Okay, the second big part of the private sector, sorry, my writing is not that good, is the hospital groups. What are the hospital groups? Netcare, Life, that actually own hospital buildings. Yeah, okay. That actually own hospitals. And they're different from the practitioners. If you are a doctor and you want to have a practice at a Netcare hospital, you are becoming part, you're signing a contract with that hospital that you're going to work there for them. Okay. And you're going to make contract fees with them. Okay. And that the third group that was just mentioned now, which is also different, is the funders or the insurance. So that's Discovery Health. That's those separate things that are paying for your medical schemes. And you can see how there's three different things. If you are a GP, or if you're a specialist at a hospital, you are the practitioner, okay? But a patient comes into you, where do they see you? In your office, which is at a hospital building owned by a hospital group, okay? And when they pay you, they don't pay out of cash a lot of the time. They normally pay with their medical aid, which is the third thing. And so those are three different businesses. You said it's a business, but there are three different businesses that are working together or not working together, okay? And that's what the HMI tried to take a look at, how you can make it better, okay? So in the hospital groups, there are three big hospital groups that I've already mentioned, hey? So I said that there is Life, I said that there is Netcare, and I said that there is Mediclinic, okay? 83% of all hospital beds in the country, in private, are owned by those three groups. Three companies that own 83% of it. Eh? So that's Life, Mediclinic, Netcare, own 83%. So it's about a third each, eh? 1/3 each. They each have about a third of that bit. There's a small group that's outside of it, little small practices and things like that. But because they have so much power, these big hospital groups, if a small little private hospital wants to start up and charge less prices, it can't compete with the large groups. Okay, so that's why very often you don't see these smaller private hospitals starting up in areas. Yeah.
So I'm just sitting here thinking. So does companies, in terms of Woolworths and those expensive,
Yes.
outlets, do they also have a say, or do they have a percentage of do they have a percentage of hold on the scene?
Yeah.
I'm just thinking about those people that are not ventured,
Yes, yeah, that's a good way to go back to the metaphor. So this is the hospital groups. If we go back to the Woolworths metaphor, imagine you want to start a spaza shop, okay? The private sector says competition is good, competition lowers down prices, but you want to start a spaza shop. You want to start a private hospital, okay? You want to start a small for your community. You want a hospital in wherever, okay? And you want to start it, and you want to have it lower prices, etc., etc. So you want to start a Woolworths, but you want to start a little spaza shop, okay? Now, you try to buy oranges or tomatoes or potatoes to sell at the spaza shop, or to buy chips to sell at the spaza shop. You have to go and buy maybe a few big packs of it. You have to buy it from someone, you understand, before you can sell it. Woolworths or Pick n Pay, these big companies, have so much of the purchasing power, they can go to the farmers and say to the farmers, I'm going to buy 1 million potatoes from you if you charge 1 cent a potato from me. Okay. A spaza shop can't do that. A spaza shop has to take the price somebody else has set for them. So the same thing is happening with the hospital groups. Okay. Because these big hospital groups exist, smaller hospitals or smaller groups or smaller little practices that don't want to work in this sector and want to charge their own prices and have competition just really can't compete. Okay, they just really can't compete because of the scale of these other companies. And so, because of that, these hospital groups don't really care about reducing prices. Okay, because what does reducing prices do to them? If patients aren't going to go to a different place, it doesn't make a difference if we reduce the price or not. Eh? They can only go to one of the other two hospital groups who are keeping the prices the same. Okay, okay. All that they really care about, if their budget is to be, for their board and etc., is making sure that it's a high daily rate for a bed in a hospital. Okay, that's what a hospital group really cares about. Okay? It's meaning that for every patient who stays there, I want to get X amount of money for my hospital group. Okay, that's their job. That's what businesses are meant to make money, and that's what they're meant to do. Okay, you know, so they make profits on a daily rate for your hospital that they set. Okay, and this daily rate is informed by what doctors are asking for, etc. All of the private doctors' rates, etc. But there's no system that is capping the prices or saying what they must charge. You understand? There's no system that's saying what doctors must charge, okay, for their for their patient. So again, maybe you have a doctor who does hip replacements, and he thinks or she thinks that they are very good at doing hip replacements. They're the best in the country, and they want to charge 200,000 rand for their hip replacement. Okay, and that's what they think they're worth. They are welcome to charge it. Okay, if somebody is going to pay for it. There's no caps on the prices at that point. Okay. And that's something that the HMI looked at. Okay. Then if we go to practitioners, so I say that's part one, that's the hospitals. Practitioners is everyone you spoke about. It's the GPs, it's the physiotherapists, it's the dentists, etc. Okay. The HMI says we don't even have a database of these people. Database is we don't have a list of everyone who's working in the private sector. We don't know actually how many people work in the private sector. Okay. And that makes it very difficult to make sure people aren't doing two things at once. Okay. We call this RWAPs. Have you heard of RWAPs before? RWAPs is when perhaps a doctor or a nurse is not getting enough salary in the public sector, so half their time they go and work in the private sector for a bit of extra money on the side. Okay. And there's certain regulations around it, but because there's no database to actually tell if somebody's working in the private sector or not, we're trusting people to report for themselves. They're trusting them to go to their boss at the hospital and say, I'm also working for Netcare on the side, etc. Okay. And there's also no price references for them. So again, there's no price lists. They can set whatever price they think they will be paid for by the medical schemes. Okay. Sometimes the medical schemes won't pay that much, and then people have to pay out of pocket. But if somebody will pay, they can charge it. Okay. The only thing that's controlling what you set to the price as a private doctor is whether somebody's going to pay or not. Okay. Whether the medical schemes will pay or not. And because of this, because there's so many doctors in the private sector, okay, especially in the urban centers like Cape Town or Joburg, etc. And they're all competing with each other. They're all wanting to give services because they get paid per service. They get paid for every injection they give or for every operation they do. They don't get paid a salary, they get paid for every service. Okay? What that means is that we get something called supply-induced demand. Okay. Basically what that means is that because there's so many people offering these services, they want you to get treatment with them, okay, it makes people spend more money on healthcare that they don't need for services that they don't need. Okay. Okay. Things like being admitted to hospital. Okay. So the South Africa has one of the highest rates in the private sector of people being admitted to hospital instead of being treated as an outpatient. Okay. So HMI looked at 17 countries in the OECD and found that our private sector has the highest admission rate. I mean, you can say sometimes that's good because it means people are getting access to services that they're not getting in these other countries, but actually this admission rate is going up about 2% a year, okay, of bed admissions. The private sector, because it gets paid per service, per injection of things, wants people to be in the hospital, you understand, okay? And that's, like I say, again, it can be good if you need hospital care that you can get in the hospital, but it also means the spending goes up and up and up and up because people get tests, they get operations, they get medication, and more and more and more and more and more and more, and that's what makes the price go up, okay? So again, it's like you're going to the Woolworths, and when you go to the Woolworths under the NHI, somebody's like, oh, do you want this as well? How about some extra sweets? You know, they're advertising, they're just giving you more and more and more and more. Okay, and by the end of the time, you went there to buy potatoes, but you've spent 1,000 rand somehow. Yeah? Okay. So that's what the HMI then said. Okay. We call that supply-induced demand. Even the ICU rates are higher. Okay. Then the third group that we looked at, remember, is the funders. This is the big one, hey? So the funders is the discovery, it's the momentum, it's all of these medical schemes that people, it's the clientele life, it's the life insurance, all of these, so Dotcha for pets. Yeah. So, yeah, for pets, you can have insurance for anything at this day and age. You have to, yeah, for your car, for everything. Okay. There are so many different schemes. If you are trying to, if one of us wanted to get medical insurance today, and we had enough money to go and get private medical insurance, and you went and you phoned up Discovery, or you phoned up one of these groups, there are so many different options for what you can choose as a plan. So many different options. And they say it's because they like to give people a choice. Okay. That's what they say. They say it's because choice. We want to give people the option, do you want a lot of coverage? Do you want a little bit of coverage? Njalo, whatever. A little bit of this, a little bit of that. But the actual reason that they're doing it is to make it very complicated for you to see what you're getting. You understand? They make it very complicated because funders, so like I said, hospitals are competing on daily rates. Practitioners are competing on who will pay, if they will pay. But the funders are trying to get as many people who are healthy into healthy schemes, and the sick people, they're trying to limit how much they pay those people. That's what the private funder does. Okay. So it wants it to be a little bit confusing so that people don't know which is the best plan for them. Okay. So there's some things that people have done, like the PMBs. Have you heard of prescribed minimum benefits? So every funder, every Discovery insurance has to pay for something called PMBs. That means that they can't say no to, like we said, the TB care or something like that. They can't say no to a basic operation or something like that. But there's all of these extra things that they can say no to and they will say no to. So you often see people really fighting with their insurance to even get money paid out to them. Okay. And when you go in to get your insurance, there's a waiting period. Waiting period. Which makes sense because, if you're sick today and you go and buy insurance, but you're sick, you're going to be spending money for the thing, so they make a waiting period. They give you however long it is. If you haven't had a medical scheme before, you must wait before you can claim. You understand? Okay. But now there's these PMBs. Okay. And what the HMI says is that what we need is a standard package. Okay. Instead of all of these different choices that people don't know what they're signing up for, and then when they actually need healthcare and they claim, it says, no, you're not covered for that, which is what often happens. And so then the medical schemes don't pay out money and they gain money by not paying out. You need to have a standard set, a set of things, whatever it is, 1,000 different things that every insurance will pay out, the basics. Okay. And you need a list of it, which there is not at the moment in the private sector. Okay. So that would be a standard package.
That's why you also don't have to sign policy about it's Discovery or whatever, because that's why they say we're recording for recording purposes. Is that also a way of they getting people to sign up what you're not signing any papers? Yes, yeah. Is that something that is
I'm not quite understanding.
People can challenge when people want to not use anymore the package.
The contracts that,
Yes,
that you do
yeah.
over the phone.
Because, yeah.
I don't think so, but I think it's, a little bit like when you're trying to get a Vodacom contract. They just bamboozle you with so much information. And it's so confusing, and you're under pressure.
Yes,
but what about if this happens? What about if that happens? And that you don't fully understand. And then, but I don't think it's legally challengeable.
Yeah.
But the way that they regulate it doesn't protect the user of the system, which is what the whole health inquiry was about.
Yeah.
How do we protect people? And if the system is not set up to make it easy for you to choose in that way, then it's wrong.
Yeah.
Yeah. Yeah. So I spend most of my time thinking about healthcare, talking about healthcare, etc. If you ask me today, what's the best medical scheme for me to get, of all of the different options, the thousands of options, I don't know. That's how complicated it is. Okay. I don't know which is the one that's saving me the most money, that's most efficient, that's, you know, getting the most bang for my buck. Okay. Because it's so complicated. All I know is I want to be covered for these things, and so I'll pay whatever to cover for these things. Okay? But I don't know that there's a scheme right next door that's going to cover those things at a better rate. And because of that confusion, they say information is unequal, it allows for there not to be competition. You understand? Hey? If it's obvious, if like, you know, there's a billboard that says, get all your health care for 1,000 Rand, and there's another billboard that says, get all your health care, the same one, for 500 Rand, then you know. Then you can say, okay, let's go for cheaper, and that would make things get cheaper and cheaper and cheaper. But because of the confusion, things don't have to get cheaper, because you just can't see. There's no adverts in that way. Okay. And that's one of the things that the HMI said. If we have a standard package, a package that every health provider, no matter the insurance is, you know, if you're paying 500 Rand or 1,000 Rand, at least you're getting these basic things. It at least makes that competitive. Okay? The extra special things, they can still be a bit confusing, but at least the standard package. And remember, what did we went back, if we go back to the NHI, one of the things that the NHI is going to have to do, let's try and find the benefits package. Eh? Where is it? I think it was on this slide here. Is come up with a package of care, the NHI. So it's things that the HMI can happen without the NHI, or it can happen with the NHI. It's a separate document, the health market inquiry that I'm talking about now. Eh? But both of them say we need a package of care. Eh? If you're going to do an NHI, you need a package of care. If you're going to improve the private sector, you need a package of care. And somebody needs to sit down and decide what is in that package of care. Okay. Is it your health promotion? Is it your physiotherapy? Is it just your medicines? Which medicines is it? Is it the metformin, or is it the insulin? You know, is it the water pills, or is it the extra special tablets that the newest tablet on the market? You know, does everyone get a hip replacement if they want a hip replacement, or is it only people who have had problems with their hip for 5 years, you know, and tried everything else? That all needs to be set out in paper somewhere, and that's going to be set out by a committee. Okay. So we'll go back now to where you can actually engage with the NHI. And we don't know who's going to be on the committee. Eh? We don't know who these experts are that are going to come up with these packages of care. There are some packages already. For example, in the public sector, you already kind of have a package of care. Eh? Because there's certain things the public sector doesn't give you. You know, you can't go today to the public sector and say, I want this new drug I saw on the TV. The public sector has what it has, and it gives you what it has. You know, and it's a list. It's the same. It should be the same at every hospital in the country. Okay, we can talk about why it's sometimes not the same at some hospitals, and some provinces struggle. But they should have the same list of medications and the same treatment protocols. But the private sector has none of that. Eh? Some private sector hospitals or doctors can choose to give you a cheaper drug, or some can choose to give you an expensive drug. It's their choice, you understand? And that's what makes the price go up and up and up in the private sector. Eh? So if some of those recommendations I talked about, even if we forget about NHI, even if NHI takes 40 years to happen, if we can make some of those changes to the private sector, we can reduce the price of the private sector and make NHI more possible in future. Eh? Reduce the price of the Woolworths at the same time. Okay. How am I doing for time? So I wanted to say that this little, one of the slogans that I just mentioned about engagement, we can call it what you want. You can call it stakeholders, you can call it community engagement, you can call it participation, whatever. Where in the NHI can you currently participate? Okay. And let me draw for you where you can currently participate in the NHI. Okay. In the NHI, where it says you can currently participate, NHI is going to be done in 2 stages. This is what the minister has said. Hey? Stage 1 is from 2023, which has already happened, to 2026. And stage 2 is from 2026 to 2028. What am I writing? Okay. 2 stages, stage 1, stage 2. Stage 1 is just getting everything ready for the NHI. It's building the systems, it's building the computer systems, it's setting up the lists, it's coming up with a package of care. Somebody has to do that. It's creating the board, it's setting up the fund, it's hiring a CEO, it's all of those things. It's going to take, they say, at least 3 years. I think 3 years is optimistic. Yeah? I think it's likely that it takes longer than that. Only after that, after 2026, are they going to start increasing the number of rolling out the NHI, facility by facility. Okay? So that means hospital by hospital, they will start saying, you are now an NHI hospital. You've been accredited, you're certified, you are now an NHI hospital. Okay. And it might happen that they do that in every province at the same time. They might already start doing it now, you know, early stages, pick a big hospital and do some pilots and things like that. But eventually, it'll be a slow rollout, is what they say, over several years. Okay. And again, 2028, I think, is optimistic that every hospital will be part of the NHI. Okay. Again, I think that's a 10, 15-year process. Okay. But that's the stages, stage 1 and stage 2. Okay. Yeah. Yeah. That's why we're going to get after the lunch break to, like, we've talked about the NHI. It's nice to know, Cordra, there are things you can do now, campaigns you can do now. That if NHI happens or doesn't happen, at least we're getting things in the right direction instead of waiting for 20 years. Okay. But let's just, so we know in the back of our heads what things the NHI says about stakeholders, okay, where we can engage, you know, just to keep things in the right direction, where are the places you can engage in NHI, okay. So like Lydia said, hey, there's the minister who has a lot of power. The minister chooses the board of the NHI, hey? The board has a CEO. And the CEO and the board look after this big pot of money, hey? That's my attempt at a dollar sign. Okay. Okay. The minister has 3 committees that he's going to set up. The benefits committee, the pricing committee, and then the one we're interested in, the stakeholder committee. Stakeholder committee. The stakeholder committee talks to the minister, okay? Talks to the minister and advises the minister, okay? We do not know who is on the stakeholder committee, okay? It is meant to be representatives of the country, of the community, of public health, of the unions, of the private sector, whatever it is. So it may be that we get things like Nehawu on the committee, or SANAC on the committee, or maybe we have some community health workers on the committee, or we have some health experts, or some NGOs, or the Treatment Action Campaign, but we don't know. Okay. That would be a good scenario if it had all of those variety of things. Maybe it is just 10 union members, 10 COSATU members, you know, or maybe it is 10 friends of the minister. I don't know. That's all I can say. Even if it is, yeah, even if it is 10 of us, even if I say tomorrow you won the lottery, 10 of you in this room are going to be on the committee, the stakeholder committee, that you are going to be the NHI stakeholder committee. The role that they have with the minister is to advise the minister. Okay. So even if it was 10 of you and you were shouting at the minister every day, the minister has a choice to listen to you or not. Yeah. Okay. So it's an advisory committee. That's a second point to make. Okay. And the third point to make about this committee is it advises the minister, not the board. You understand the difference? It talks to the minister, who is meant to then talk to the board and say all of these things, but it doesn't talk directly to the board. Okay, okay. So maybe there should be some participation on the board as well. Okay. And again, boards, there's ways boards are made. Boards are meant to be including participation of experts and community members, but the board is going to be appointed by the minister. So again, the board could have friends of the minister. Okay, okay. So one of the things that some of the other groups in the country, Section 27, was asking for was that instead of reporting to the minister, the board should report to Parliament. as a whole, because at least it's more than one person they're talking to. Okay. But unfortunately, the way the bill is at the moment, they report to the minister. Okay. So this stakeholder committee is going to have to do magical things. Eh? But it exists. It exists, and at least it's there on paper, and we're not going to get ahead of ourselves, but maybe it's going to be fantastic. Eh? Okay. Where else can you talk? Okay, yeah, sure.
So my question is, as the community, what can we do to get into the stakeholder community?
Yeah.
What is the community?
Yeah. So we don't know, but what we do think is that there will probably be a call that comes out, like an advert that comes out that people will be applying to be part of the committee. See? But we don't know how that process will be, and there's been no dates on it. Eh? Even in these dates, they say this is for setting up the board, setting up the committees, etc., but it doesn't have a set date on when these committees are going to be set up. Okay.
The board doesn't exist yet.
Yeah, even the board doesn't exist yet. There's no CEO at the moment. There's just the minister. All of these, now that the bill has been signed this year, all of these other jobs need to be created. Eh?
Right, just as part of that board.
Yes. Yeah. Yeah. I mean, we know of boards of different companies in the country.
So is it the advisory committee that does all the planning? Because they first speak to the minister before the minister speaks to the board.
Yeah. So there's these other committees which I didn't talk about here, but they have other jobs which are slightly different to the stakeholders. The stakeholders is to advise on what it's like for South Africans. Eh? That's what the stakeholders is meant to be about. It's about you've made this policy, you should consider this effect on the economy, or you should consider this effect on the working people, or you should consider this effect on disabled people, or whatever it is. Eh? The pricing committee has a different job. Its job is to come up with a set of prices, like Lydia was talking about, for services. Okay? Maybe it says a C-section, you have an operation. Maybe it says we will pay between 10 and 20,000 for that. I'm sucking the number. Okay. And they will set a price, but they must come up with a price that makes sense. That's somewhere between the Woolworths price and the Boxer Superstore's price. So that the private sector will want to be part of it, but so that the public sector is not paying Woolworths prices for its services. Okay. The benefits committee is the one that I said must come up with that standard package of care, that come up with a list of everything you can possibly get treatment for in the NHI. So they have different jobs, and they're going to have experts on these different jobs. Okay. Where else can you join the NHI and actually talk with government? Okay. Did we talk about cups? No, we didn't talk about cups. Okay. The NHA, this money is going to be paid to hospitals, to EMS, to GPs, whatever it is, through something called a cup. Okay? CUP stands for Contracting Unit for Primary Care. You don't really have to remember the actual word. Contracting Unit for Primary Care is the smallest unit of the NHI. Okay, it's the smallest area that the NHI provides for. Okay, it will include a local CHC. Let's just say it's in your community, a community health center, all of the local GPs in that area, and maybe a district hospital. That's one cup. Okay, and there will be hundreds of cups around the country. You understand? Okay, so maybe Guguletu will be a cup, or maybe Kairicha will be a cup, or maybe Kairicha will be 2 cups. You know, think of it like districts. Okay? It's like a district. Okay, it's a little bit smaller than a district, but it's like a district. Okay, and anyone who joins the NHI, so if you're a patient over here, wherever, you will go to your district, your cup, which will have a hospital, which will have GPs, which will have a referral network that you will follow through, etc., etc. You won't just go to a random other doctor that you choose. You understand? You'll go to your cup. But the cups are going to have to manage this amount of money. They have to manage money coming from the fund for paying for a district hospital, for paying for the GPs, for paying for the patients who's going to the physios under the cup. Okay. The cup is managed by district level managers. Okay. Something called the DHMO. But just think of a district health management office. District health. You know of district health councils? So district health councils exist today. Every district in the country, whichever district you're from, has a health council, okay, who advises the province from that area, okay. These district health councils are going to get more power under the NHI because they're going to have to run CUPs, okay. So that's what we're going to say. And the NHI says district health councils must increase the amount that they talk to communities, okay. That's what it says. It says that's actually about one sentence, okay. So somewhere here in the district councils, there's going to be a space for communities to engage as well, okay. That's really as much detail as we have at the moment on the district health councils. So if you go to your own community now and you think of your own community now, how many of you have never heard of their district health council in your community? Or have never seen or met with your district health council? I have never met a district health council for my community. There's meant to be one for every community. Every district in the country has a district health council, okay? And they are going to be the space where communities will be able to talk about the CUPs. Yes, Shasha.
Sorry, what you're saying is my first time I'm hearing about the district health council. Now, in our communities, who is supposed to be our district health council here?
So the district health councils, it's a great question. I had to learn all of this in the past few weeks. Yeah. The district health, I actually have the list. It's in the National Health Act. Eh? So it's in a piece of legislation called the National Health Act from 2004 that says who's in the district health councils. Eh? I can't remember the exact details of the people, but it's something like the local ward councillor, local facility managers, somebody who's a representative for the MEC, and I think it says 5 other members. It doesn't say who those 5 other members must be, okay? And it meets, I think, quarterly, once every 4 times a year at least, okay, the district health councils. Okay. Every district is meant to have one. Lots of districts don't have one, or they've been forgotten about, etc. Okay, and they are meant to come up with every year a district health plan. Every year, district health council is meant to come up with a district health plan, which means your district, whatever it is, if it's Guguletu district or wherever your district is meant to have a plan for its district that you should be able to read as members of the public for the district. Okay? But that's not happening. Okay. But the NHI says they're going to strengthen these district health councils. Okay? They're going to make them able to not just make health plans, but also to talk to communities and then also to run the CUPs. Okay. So a lot of extra staff is going to need to happen at the district health councils. Okay. Okay. In the entire NHI bill, those are the 2 places that it says anything about communities. It says it up in the stakeholders committee at the top with the minister, and it says these district health councils, district health management office, which is at the district level. Okay. Those are the only places in the bill that says anything about community participation. You understand? Okay. Can you think of problems with that? You understand?
Yes.
Yeah. Yeah. It doesn't say anything about CHWs, community health workers. It just doesn't say anything. It doesn't say good or bad or anything like that. It just doesn't even mention them. Okay. It doesn't mention hospital boards. It doesn't mention clinic committees. It doesn't mention health forums. All of these things that exist for years and years and years are not mentioned in the NHI. It doesn't say it's getting rid of them, but it just doesn't mention them. Okay.
Council are supposed to be local ward council facility managers in 5 members. Who are these 5 members?
I'll give you, just after this, I'll look it up on my phone. I've got the actual document from the bill that will say what it says in the act, and I can give it to you. I'm not sure if it's 5 or it was 4. I can't remember. And what I think I remember is that the 5 members are members appointed by the MEC. Okay, so the MEC will appoint each district to have a representative for them, and then it's really up to the district to decide. Maybe they decide they want some health experts, or maybe there's a strong NGO in that district, so they put someone from that NGO on, or maybe there's a strong health activist in that district. They leave it up to the districts to decide, to be flexible on that. Yeah, yes, sure.
I want to say, in our province, The district health council, we found them in Premier's office. And it's made of a member from TAC, a member from NAPWA, and also a AIDS unit, the one that I was saying they were going to provide us with a peer educator training. We found them inside that Premier's office. So I don't remember who are the other members or the stakeholders who formed that council.
Yeah, that's interesting.
But inside the Premier's office, you'll find them there.
So that's interesting. So in this example of the District Health Council, she's saying there's a TAC member, a NAPWA member, but it might be different district by district. Yeah, and not every district has a TAC that's active in it. You understand? Yeah. Oh, here you've got it. Yeah.
Traditional healers and other stakeholders.
Yeah.
Community health care, provincial, local government, practicing and traditional healer and other stakeholders. That's a conversation.
Yeah. So the other stakeholders is vague. It can be anyone really, and it's up to the district. But the other, it says, like it wants traditional healers and community members and NGOs and maybe church groups, religious groups, but it's all put in other. So it's kind of open to whatever the district decides. It doesn't say it has to be TAC, it has to be Nahawu, it doesn't say any of that. It leaves it up to the provinces. Okay. Sure.
Is it possible that we can get the document?
Yes, sure. I mean, this is from the National Health Act. I can give you the quotes after this. I'll write them out for you guys. Yeah, she's got it on a. Yeah, it should be in the manual somewhere. I'll find it for you now. Okay. Yeah. National Health Act. Yeah. Okay, so we're getting to 1 o'clock now. Okay, so lunchtime approaching, or lunchtime is going to be now, but just to summarize like what I'm saying, hey, and so that when you go back and you come back from lunch, we're going to now move from some of these topics on, hey. So we've talked about the NHI, we've talked about the health market inquiry, the ways to reduce the price of the Woolworths so that if it joins together, it's not so expensive. And we've talked about the NHI having only two places that are kind of vague for communities to participate, the Stakeholders Committee and the District Health Management Office, District Health Councils with the cups, okay. After the lunch break, okay, Nori, myself, Lydia will be leading a session on actually looking at advocacy you can do in your communities, okay. Actually thinking of, like, NHI is happening in the background, but what are the step-by-step advocacy we can start running with now instead of waiting with our arms folded, like on all of the things we've mentioned already. On accreditation, what can you start getting done in the background so your facility gets accredited? What's the things you can start getting it done in the background so that people get registered and get their birth certificates and documents so that they can get access to NHI? All of those things we're going to be working through locally and nationally after the lunch break. So I think any last questions on the NHI part of the day? Sure.
Okay, Dr. Lydia, I think maybe you answer or NHI maybe the community asked me about when is the time, maybe after 3 and 5 years, how to do a restoration or put in hospital for the NHI. My question is, anyone can go to for the restoration, and my question, those that have a smartphone, what must do?
So, I mean, we don't. The first thing that will have to happen is the information computer system has to be set up for the whole country. And some of the announcement of the money put aside for NHI recently, there's some money that's put aside is to create that computer system. Then the whole population needs to be registered onto that system, which will probably have many different ways of registering. There will probably be places which you can go to physically register, and probably an online option also with a computer or a smartphone. But it shouldn't be that if you don't have a smartphone, you can't register. I mean, there are places where people don't have network and that kind of thing, or elderly people who don't know how to do it. So we don't know, but I would imagine that when it gets to the point where you can now apply to register, there will be many different ways to do it. And once you have the card, it will depend on which facilities are already in and part of the NHI in your area, and within the care pathway that has been outlined. So, the timeframes have been optimistic from the beginning with NHI. So I think maybe in 3-4 years we might see the information system kind of ready to run, and maybe the board will be set up. But and there will be some pilots. So there will be some communities where they will try and practice some of the models. Let's try CUPS here. So I know the Western Cape Department of Health is going to try and do some CUPS type processes. So you might hear of someone saying, oh, actually in my community, the GPs are contracted in and I can go to them. So you might hear about those, but it's not across the whole country. They're going to be these little areas where they will try things out. But I suspect a population-wide rollout is going to be some time still. But I think it's interesting to be able to think of NHI, not to feel despair about here comes another mad plan, but to say, okay, there are opportunities within this thing. How do we campaign and organize so that we get the best possible for our communities right now? And right now we need to improve our public health system. How can we leverage the attention being paid to NHI to fix our health system? And hopefully in the afternoon, that's some of the work that we can do.